Namaste, everyone, and welcome. Today, we are going to tackle a very, very important topic, one that you will see again and again in your clinical life, the pathology of the breast. So in this first part, we're going to build a solid foundation, okay? We'll cover the normal anatomy, and then we'll move all the way up to the very first signs of cancer. Chalo, let's get started.
Right, let's begin with a situation straight from the clinic. A patient comes in and her mammogram report says there are calcifications. Now, the first question that pops into everyone's mind is it cancer? This is a huge dilemma you will face all the time. But to answer this question properly, we have to start from the very beginning. And that beginning, of course, is the normal anatomy. Listen, you cannot, I repeat, you cannot understand what is abnormal if you don't have a crystal clear picture of what is normal. And the breast, it's not a static organ. It's always changing. So understanding its basic structure is absolutely essential. Okay, look here. This is the heart of the matter, the terminal duct lobular unit, or what we call the TDLU. Please remember this name. If you think of the breast as a big city, the TDLU is like the main shock, the central square where everything happens. It's the functional unit, and it's the place where almost all breast diseases, good ones and bad ones, benign and malignant, they all start right here.
You see, the breast is not some fixed structure, yaar. It's alive, constantly responding to hormones. At puberty, the ducts and lobules start to grow. Then, just like the endometrium, it goes through changes with every single menstrual cycle. During pregnancy, it reaches its full maturity to produce milk. And finally, as a woman ages, it goes through involution, where all that glandular tissue is slowly replaced by fat. This whole life cycle is why we see different diseases at different ages.
So a patient feels a lump. Immediately, the mind jumps to the worst-case scenario, cancer. But as doctors, we have to be calm and systematic. A lump can be caused by so many things, and very often it's just a benign inflammatory condition, basically a false alarm.
And here is a number you should commit to memory. Over 90%, more than 9 out of 10 symptomatic breast lesions, things like a lump or pain or discharge, are benign. Now, this is great news for the patient, of course, but it means our job as diagnosticians is even more critical. We have to be sharp enough to find that less than 10% that might be malignant. So here are two of those false alarms. On the left, we have squamous metaplasia of the lactiferous duct. This is very strongly linked to smoking in over 90% of cases. What happens is that keratin plugs a duct, it ruptures, and it causes a painful mass. On the right, you see duct ectasia. Here, a duct gets dilated, fills up with debris, and causes a lot of inflammation. And the fibrosis that results from this can look just like cancer on a mammogram.
Okay, now this next part is extremely important. VVI for your exams and for your entire career. You have to understand that not all benign changes are the same. We actually classify them on a spectrum of risk for developing cancer in the future. Just look at this table. It's very simple. There are 3 categories. The first one is non-proliferative changes. Risk is 1.0. That means no increased risk at all. The second is proliferative disease, but without atypia. Here, the cells are multiplying, so the risk goes up just a little bit, maybe 1.5 to 2 times. But the third category, proliferative disease with atypia, that word, atypia, changes everything. As soon as you see atypical cells, the risk jumps up to 4 to 5 times. Here's a perfect example from our no-risk category, cysts. Extremely common. Under the microscope, you see these lovely apocrine cells with abundant pink cytoplasm. This is what we used to call fibrocystic disease. And remember, it carries 0 increased risk of cancer. Now, moving on to category 2. This is sclerosing adenosis. You can clearly see there is a proliferation of glands, right? An increase in the number of acini. But notice how the stroma is squeezing and distorting them. To someone who is not experienced, this can look very scary. It can even mimic an invasive cancer. But the cells themselves are benign. There is no atypia. So the risk is only slightly high. And now, category 3, proliferative disease with atypia, or ADH. Here, the whole game changes. The cells are no longer a happy mix of different types. We see a single, monotonous population of cells, and they're forming these rigid, structured patterns, like these cribriform spaces you see. It's starting to look a lot like a low-grade cancer, and this is a major red flag. So, we have climbed the ladder of risk, haven't we? From no risk to a small risk to a moderate risk with atypia. So what is the next logical step? Well, now we're standing right on the edge. We are moving away from just risk factors and into the territory of actual non-invasive cancer, carcinoma in situ. The name tells you everything. Carcinoma in situ. It means in its original place. The cancer cells are there, no doubt about it, but they are confined. They are trapped. They have not broken through the basement membrane. Think of it like this. The bad guys are inside the house, but they haven't broken down the walls to get out into the street. The cancer is contained. So if it's contained, what's the big deal? Well, the risk is the big deal. A diagnosis of carcinoma in situ means an 8 to 10 times increased risk of developing invasive cancer later. So you see, this is no longer just a risk factor. No, this is a direct precursor lesion. The cancer process has already begun.
So how do we find this contained disease? Most of the time, a patient can't feel it. We have to see it. And this mammogram shows the classic appearance of ductal carcinoma in situ, or DCIS. These tiny, linear, branching calcifications. You know why they form? Because the cancer cells in the center of the duct die, and that necrotic debris then calcifies. This picture right here is why screening mammography is literally a lifesaver.
Now, carcinoma in situ comes in two main flavors. We've just talked about DCIS. The other one is LCIS, or lobular carcinoma in situ. And knowing the difference between these two is absolutely critical. So let's put them side by side, a showdown between DCIS and LCIS.
Please pay close attention to this. In DCIS, the cells form structures and patterns. They cause those calcifications we see on the mammogram. And the key molecular reason is that E. coherent, the glue that holds cells together, is still present. The future risk of cancer is mainly in the same breast. Now look at LCIS. Totally different story. The cells are discohesive. They don't stick together. Why? Because they have lost their E. coherent. This is the single most important difference. Because they're loose, they don't form structures. They don't calcify. So we usually just find them by accident on a biopsy. And the risk? The risk is for invasive cancer in both breasts. And the microscope slide makes this difference perfectly clear. On the left, you see DCIS. See those round, punched-out cookie-cutter spaces? The cells are cohesive. They're sticking together to build something abnormal. Now look to the right. That is LCIS. The cells are just loose, floating around, filling the space. They have lost their discipline because they have lost their ecahedron glue. It's a beautiful demonstration of molecular pathology.
So before we end this part, I want you to burn this thought into your memory. The cancer is contained, yes, but the basement membrane is the only thing holding it back. It is a very fragile wall, standing between a problem that is contained and an invasion that could threaten the patient's life.
And that brings us to the final, obvious question. The cancer is contained, for now, but what happens when that wall is finally breached? What happens when those malignant cells escape the ducts and lobules and invade the stroma? Well, that, my friends, is invasive carcinoma. And that is the very exciting topic for part 2 of our discussion. Study well, and I will see you next time.
All right, everyone, welcome. Today, we're going to play detective, okay? We're going to investigate one of the most common and also one of the most complex diseases out there, invasive breast carcinoma. So what's the big mystery here? Cello, let's find out. Look at this number, 1 in 8. Just think about that for a second. That is the lifetime risk for a woman in the United States to get breast cancer. It's a truly staggering statistic, isn't it? It just shows you how common this disease really is.
But, and this is the most important point of our entire discussion today, not all breast cancer is the same. It's not one single enemy. No. It's what we call a highly heterogeneous disease. It has many, many different faces. And our job today is to understand all its different avatars, you could say, and figure out how to tell one from the other.
So here's our plan of attack for today. First, we'll look at the global picture. Then we'll go under the microscope. After that, we'll decode the biomarkers, check out the cancer's genetic ID, look at a gallery of subtypes, and finally, put it all together for the full diagnosis. Ready? Let's go.
Okay, first things first. Section 1, a global health challenge. Before we get into the nitty-gritty, let's take a step back and understand the sheer scale of this problem. So get this. In 2020, breast cancer actually became the most common cancer worldwide. Can you believe that? 2.3 million new cases in just 1 year. This isn't just a problem for one country. It's a leading cause of cancer death for women all over the globe. It's a massive, massive health challenge for all of us.
All right, now for the fun part, at least for us pathologists. Section 2, under the microscope. This is where our real detective work starts, with the first piece of evidence, the tissue sample. The whole story of the diagnosis. It begins right here. Now, before we jump into looking at the slides, you need to understand a very important concept, histologic grade. So what is it? Think of it like giving the tumor a report card. We're grading it on how much it resembles normal breast tissue. And we look at 3 things. First, tubule formation. Are the cells making proper structures? Second, nuclear pleomorphism. How much do the cells vary in shape and size? And third, the mitotic rate. Basically, how fast are these cells dividing? That's our first clue about the cancer's behavior.
Okay, look at this. See how organized these cells are? They're forming these nice, clear tubules. This is a grade 1 tumor. We call it well-differentiated because, well, it looks the most like normal tissue. It's the most well-behaved of the lot, you could say.
Now look at this one. See the difference? Things are starting to get a bit messy, a bit disorganized. There's less of that nice tubule formation, and the cells themselves look more varied. This is grade 2, our intermediate step. We call it moderately differentiated.
And here, wow, this is grade 3. It's just complete chaos, isn't it? You see these ragged nests of cells, the nuclei are all irregular, and you can tell they're dividing like crazy. It looks nothing like normal tissue. This is what we call poorly differentiated, and this is a high-grade aggressive tumor.
So, the grade gives us a very important first impression, but it's not the whole story, not by a long shot. To really understand what we're dealing with, we need to go deeper and look for molecular fingerprints. And these are what we call biomarkers. And in our investigation, there are 3 main suspects we are always looking for. These are the big 3: estrogen receptor, or ER, progesterone receptor, or PR, and a protein called human epidermal growth factor receptor 2, or just HER2 for short. Whether these guys are present or absent is absolutely critical. Why? Because it decides the entire course of treatment for the patient.
So based on those 3 biomarkers, we can divide almost all breast cancers into these 3 major clinical groups. You have the luminal group, which is ER positive and driven by hormones. That's the biggest group. Then you have the HER2 group, which is, you guessed it, driven by the HER2 protein. And finally, you have triple negative, where all 3 of our suspects are missing. Each one is a totally different beast with its own biology and its own treatment strategy.
Okay, time for some deep forensics now. Section 4, the cancer's genetic ID. We need to ask a really fundamental question here. Did this cancer come from an inherited clue, something passed down in the family? Or was it from mutations that were acquired over a lifetime? So this slide breaks it down nicely. On one hand, you have familial cancer. This is caused by inherited gene mutations, and you've probably heard of the big ones BRCA1 and BRCA2. This accounts for maybe 25 to 35% of cases, but the majority, about 65 to 75%, are sporadic. These are caused by acquired mutations that build up over time, and a major factor here is often estrogen exposure.
But wait, we can go even deeper. Beyond just those 3 biomarkers, we can actually look at the expression of hundreds of genes. This is called gene expression profiling, and it gives us what we call an intrinsic subtype. Think of it as finding out the tumor's true personality. This gives us super detailed profiles like luminal A, luminal B, and basal-like, and these can predict the tumor's behavior with even more accuracy.
All right, now this is the really cool part. Section 5, a gallery of subtypes. Let's look at the mugshots, if you will, of some of the special characters in the world of breast cancer. These guys have such distinct looks under the microscope that they give us immediate clues.
Ah, a true classic. This is invasive lobular carcinoma. And what's its signature? Look closely. You see those single-file lines of tumor cells? It's like they're soldiers marching. We call this Indian filing. And you know why this happens? It's because the cells have lost a protein called E-cadherin, which is basically the glue that's supposed to hold them together. Okay, now for something completely different. This is mucinous carcinoma. Just look at that. The tumor cells are literally floating in these huge, glassy pools of mucin. It gives the whole tumor a very different, almost jelly-like feel. Isn't that fascinating?
Now just look at this contrast. It's night and day, right? On the left, you have tubular carcinoma. It's so orderly, low-grade, ER positive, well-behaved. And on the right, metaplastic carcinoma. It's high-grade, triple negative, just total chaos. This really shows you the huge spectrum we're dealing with. They're all called breast cancer, but they are such different diseases.
Okay, so we've gathered all our clues.
We've looked at the grade, we've checked the biomarkers, we've understood the genetic background and the histologic subtype. It's time to put it all together and make our final diagnosis.
This is how we do it in modern pathology. It's a step-by-step process. First, you assess the morphology and grade under the microscope. Then you test for the biomarkers, our ER, PR, and HER2. After that, you determine the specific histologic subtype. And all of these clues together, help guide the treatment plan.
And this is the take-home message, okay? From the morphology to the molecules. Every single layer of this diagnosis is critical. This isn't just some academic exercise we do for fun. It has a direct, profound impact on creating a personalized treatment plan for the patient. This is what saves lives.
So I'll leave you with this final thought. We've cracked this case, for now, but the mystery is always getting deeper. As we understand more and more, how will the next generation of therapies target the unique genetic fingerprint of each individual cancer? That's the future you all will be a part of. Think about it. Welcome back, everyone. Today, we're jumping right back into Chapter 23, and we're talking about something absolutely critical: figuring out the prognosis for a patient with breast cancer. I'm telling you, this isn't just for your exams. This is something you'll be doing every single day in your practice. So let's get our clinical hats on and dive in.
So picture this. You have the biopsy report. It's confirmed invasive carcinoma. The patient, their family, they're all looking at you. They want answers. Now, before you can even think about treatment plans, what is the absolute first thing you need to figure out? It's all about understanding the enemy you're up against.
And that's where our investigation begins. Section 1, gauging the enemy. Look, before we get into all the complex biology and molecular stuff, we first have to assess the physical reality of the cancer. How big is it and where has it gone? This is the absolute foundation of everything that comes next.
This whole process is called determining the anatomic stage. Think of it like a detective arriving at a crime scene. Your first job is just to map everything out, to understand the physical extent of the problem. It's a fundamental method we've used for a long, long time, for a very good reason. To do this, we use the TNM system, and you all have to know this by heart. It's actually quite straightforward. T is for the size of the primary tumor. N is for node involvement. We're talking about the nearby lymph nodes, usually in the armpit. And M is for metastasis. Has it spread to distant organs? T, N, and M. Simple as that. Just look at how much the tumor size alone tells us. If the tumor is tiny, less than 1 centimeter, the 10-year survival is fantastic, over 90%. But if it grows just a little bit to over 2 centimeters, that survival rate drops all the way to 77%. This shows you exactly why early detection, why screening, is literally a matter of life and death. Okay, now listen very carefully to this next part. This is a favorite exam question, but more importantly, it's a golden rule in the clinic. Assuming the cancer hasn't spread to distant organs, the status of the axillary lymph nodes, the N in TNM, is the single most important prognostic factor. Remember that.
Let's look at the numbers, because they really tell the story. With 0 lymph nodes involved, the 10-year survival is a very hopeful 70 to 80%. This is the kind of prognosis we like to see. It tells us the cancer is still localized.
Now for the contrast. Look what happens if more than 10 lymph nodes are positive. The survival rate just collapses. It plummets down to just 10 to 15%. Going from nearly 80% down to 15, that huge drop shows you just how powerful that N component really is.
So while T and N are absolutely critical, the moment you find distant metastasis, the moment M becomes positive, the game completely changes. It overrides everything else. It becomes the most important factor, and at this point, sadly, a cure is unlikely. Our entire goal shifts from trying to cure the disease to managing it.
Okay, so we've covered the anatomic stage. That's the physical map of the cancer. But you know what? That's only half the story. Now, in Section 2, we're going to dig deeper. We need to understand the tumor's biology. You can think of it as its personality.
And first, we need to be very clear about 2 words that students always mix up: prognostic and predictive. A prognostic factor, like tumor size, just gives you the likely outcome of the disease itself. It's like a weather forecast, right? Rain or sun. A predictive factor, like ER status, tells you how the cancer will respond to a specific treatment. It tells you if your umbrella will actually work in the rain. And sometimes, as we'll see, a factor can be both.
So what are these biological clues we're hunting for in the pathology report? Well, we look for 4 main things. We check for estrogen and progesterone receptors, or ER and PR. That tells us if hormones are feeding the cancer. We look at its HER2 status, which is a key growth signal. And finally, we look at the histologic grade, which is basically how aggressive and abnormal the cells look under the microscope.
These biological clues let us classify cancers into different subtypes, each with its own personality. So you have the luminal types, which are ER positive. They tend to grow slower, and importantly, we can treat them with hormone therapy. Then you have the HER2 positive types. These are more aggressive, no doubt, but the good news is we have amazing targeted drugs for them. And finally, triple negative. It's negative for all 3 markers, it's aggressive, and it usually means we have to rely on chemotherapy.
All right, so now we've looked at the physical map of the cancer, and we've done a psychological profile of its personality. Let's move on to Section 3 and see how we put all of this information together to create a modern, truly effective battle plan. The modern way of doing things is called the prognostic stage. This is so important. We don't just use the old TNM system on its own anymore. We integrate it with all that biological data we just talked about, ER, PR, HER2, and the grade. What you get is a much richer, much more accurate prediction of what's going to happen.
And this has real-world consequences. For instance, a small tumor that looks harmless by size might have a terrible personality, like a triple negative. This new system lets us upstage it, treat it more aggressively. And the opposite is true. A larger tumor might be a slow-growing luminal type. We can downstage it, and maybe that patient doesn't need aggressive chemotherapy. It's about being smarter with our treatment.
Now, before we finish up, let's take a quick detour. This is a crucial reminder for all of you as future clinicians. It's so important to remember that not every lump in the breast is cancer. You must always think about the whole picture.
For example, look at this. This is a fibroadenoma. It is the most common benign breast tumor. We see it all the time in younger women. See how smooth and well-defined it is? It comes from a totally different tissue type called the stroma. Its story, its prognosis, is completely different and non-threatening compared to the carcinomas we've been discussing.
Okay, let's wrap this up. Let's get to the most important part, your core takeaway. If you only remember one thing from today's lecture, what should it be?
It's this. A patient's prognosis is a story that is told by 2 main things. First, the cancer's physical footprint, that's your TNM. And second, its biological personality, that's your ER, PR, and HER2 status. To get the full picture, to really understand the story, you absolutely must have both pieces of the puzzle.
And so, I'll leave you with this final piece of advice. Don't just be a student who memorizes staging tables. That's not enough. Your most important job is to become a clinician who understands the unique story of each patient's cancer. By putting together the size, the spread, and the personality, you achieve real clinical wisdom. That's all for today. Thank you.